Today, we're going to tackle a really common point of confusion in cardiology, the difference between a heart attack and a sudden cardiac arrest. To really make it stick, we're going to lean on a simple, but I think very powerful analogy. One is a plumbing problem, and the other is a wiring failure.
Hello and welcome. This is A&P Live Studio. I'm your host, and I teach anatomy and physiology as a registered nurse and an instructor for advanced level healthcare professionals.
So let's set the scene. Imagine you're in the emergency department. Your patient is Mr. Chen. He's 64, has a history of hypertension, and he's just arrived clutching his chest. He describes this awful, crushing pain and says he just can't catch his breath. Now, this presentation immediately screams acute cardiac event, but the critical question is, which one? So here's our plan. We'll kick things off by defining these two very different emergencies. Then, we'll quickly review the heart's normal jobs before diving into the pathophysiology of a myocardial infarction and then a sudden cardiac arrest. After that, we'll look at diagnosis and intervention, and finally, we'll recap that key difference between blood flow and the electrical spark. Okay, let's get right into it. Now, while it's true that a heart attack can lead to a cardiac arrest, they are absolutely not the same thing. They really represent two fundamentally different types of failures within the heart. And, getting this distinction right is absolutely critical for how we recognize and respond to each one. And this is where our analogy really comes to life. On one side, you have the myocardial infarction, or MI. This is a circulation problem, a plumbing issue. An artery is blocked and the heart muscle is being starved of blood. The patient, they're usually awake, they're conscious, they're feeling symptoms, and our goal is reperfusion. We have to unblock that pipe. Now, on the other side, you have sudden cardiac arrest. This is an electrical problem, a wiring failure. The heart's electrical system just goes haywire, and the heart stops beating effectively. The patient suddenly collapses, they're unconscious. Here, our goal is totally different. It's resuscitation. We need to reset that electrical system. To really understand what's going wrong, we have to first appreciate how things are supposed to work under normal conditions. The heart basically has two essential and very interconnected jobs it has to do to keep us alive. It needs fuel, and it needs a signal to tell it what to do. And here are those two jobs. First, we have coronary perfusion. That's our plumbing. These are the arteries wrapped around the heart that supply the myocardium, the heart muscle itself, with all the oxygenated blood it needs to function. Think of it as the fuel line. Then we have cardiac conduction. This is the wiring. It's this incredible, specialized electrical system that coordinates every single contraction, making sure the heart pumps blood efficiently and with a steady rhythm. All right, so with that foundation in place, let's look at our first scenario, the plumbing crisis. This is the pathophysiology of a myocardial infarction, what most of us know as a heart attack. So how does this happen? Well, it typically starts with atherosclerosis, that slow, gradual buildup of cholesterol plaque inside a coronary artery. But the real crisis, the acute event, happens when that plaque becomes unstable and cracks open. The body sees this as an injury and does what it's supposed to do. It forms a blood clot, a thrombus, to seal the rupture. The problem is that clot can grow so big that it completely blocks the artery. And once that happens, all blood flow downstream is cut off. That lack of blood flow is what we call ischemia. Now let's zoom way into the cellular level, because this is where the real damage starts, and it happens fast. Without oxygen, those heart muscle cells, the myocytes, can't make ATP, their energy source. Without ATP, their ion pumps fail. This causes a huge ionic shift. Sodium and calcium flood into the cell, and potassium leaks out. That massive influx of calcium is especially toxic. It wrecks the mitochondria, which just makes the energy crisis even worse, and it activates enzymes that start to tear the cell apart from the inside. Eventually, the cell membrane loses its integrity, it ruptures, and the myocyte dies. That's necrosis. And what happens if a large area of that heart muscle dies? Well, that can lead to a really devastating complication, cardiogenic shock. When so much of the muscle is damaged, the heart simply can't generate enough force to pump blood effectively to the rest of the body's organs. This kicks off a dangerous downward spiral of low blood pressure, which in turn makes the ischemia in the heart even worse and can quickly lead to multi-organ failure. Okay, so we've covered the plumbing. Now let's completely shift gears and talk about the wiring. Sudden cardiac arrest is an abrupt, catastrophic electrical failure. The clinical definition is pretty straightforward. It's the sudden cessation of all cardiac activity. But the key phrase here is electrical malfunction. This is not about a clog in a pipe anymore. This is about a short circuit in the wiring. The pump just stops working, and blood flow to the brain and the rest of the body just stops, instantly. So here's the really crucial connection. How can a plumbing problem cause a complete wiring failure? Well, think about that dying ischemic tissue from a heart attack. Those damaged cells become electrically unstable. They mess up the heart's normal, organized conduction pathways and create this perfect storm for electrical chaos. This chaos often triggers the most common lethal arrhythmia, ventricular fibrillation, or VF. In VF, the ventricles aren't contracting, they're just quivering uselessly. No blood is being pumped, and that is cardiac arrest. And make no mistake, the stakes here are about as high as they get. For a cardiac arrest that happens outside of a hospital, the mortality rate is over 90%. That's a staggering number. It's because the second the heart stops, perfusion to the brain stops, and without immediate intervention, death is just minutes away. So all of this pathophysiology directly leads us to the clinical response, because being able to recognize the difference between these two emergencies is what dictates the completely different, life-saving interventions that have to happen next. And clinically, the presentations could not be more different. Your MI patient, like Mr. Chen, is awake. They're conscious, they're in distress, they're having symptoms because their heart muscle is being damaged, but it is still beating. Now, contrast that with the SCA patient. They suddenly collapse, they're unresponsive, they have no pulse, and they aren't breathing normally. One is a person in trouble. The other is a person who is clinically dead and needs resuscitation right now. So for an MI, the mission is reperfusion. We have to open that blocked artery, and fast. We diagnose it with an ECG, looking for those telltale ST segment changes, and we draw blood to check for cardiac troponins. That's the protein released from dying heart cells. We immediately give medications like antiplatelets and anticoagulants to stop the clot from getting any bigger. And then, the definitive treatment is a trip to the cath lab for an emergency PCI, where we can physically go in and open that artery. For SCA, the goal is completely different. It's all about resuscitation, and the clock is ticking from second one. The first step always is to call 911. The second is to start high-quality CPR immediately to manually circulate blood and keep the brain and other organs alive. And the third, most critical step, is to get an AED on the patient. That device can deliver an electrical shock to essentially reset the heart's chaotic wiring, giving it a chance to return to a normal rhythm. And of course, an event this catastrophic in the cardiovascular system has major ripple effects. With SCA, that global lack of blood flow immediately puts the nervous system in jeopardy. The brain is just so incredibly vulnerable to hypoxic injury. With a severe MI that leads to cardiogenic shock, that poor perfusion hits other systems hard too. It often causes acute kidney injury in the urinary system and fluid backup into the lungs, pulmonary edema, affecting the respiratory system. It's also really important to touch on the role of genetics here, because while we've been focused on coronary artery disease, which is the big culprit in older adults, the story can be very different for younger people. Sudden cardiac arrest in an otherwise healthy young person is often caused by an inherited genetic condition. These can be things like channelopathies, which are literally problems with the heart's ion channels, a pure wiring problem, or inherited cardiomyopathies, which are diseases of the heart muscle itself. All right, so let's bring it all home and just recap this critical distinction one last time. We've seen how one is a failure of flow, and the other is a failure of the electrical spark that makes the whole thing run. I think this analogy just sums it all up perfectly. A heart attack is like a clogged fuel line in a car. The engine sputters, it struggles, it's clearly in trouble, but it's still running. Cardiac arrest? That's the engine shutting off, completely, instantly. One is a plumbing crisis, the other, a catastrophic electrical failure. So you can see whether it's a problem of flow or a problem of spark, understanding that fundamental difference is the absolute first step in responding effectively to these life-threatening emergencies. Stay patho-curious, and I'll see you in the next A&P Live studio. Just a reminder, this video is for educational purposes only and is not intended as medical advice, diagnosis, or as a substitute for professional healthcare decisions.